Good morning and welcome to today's meeting of the Board of Directors of Lincolnshire Partnership NHS Foundation Trust. My name's Sharon Robson and I'm the Deputy Chair of the Trust. Those of you who join us regularly will know that we usually start the board with a story from either our patients, carers or staff, but we're not in a position to do this today. Instead, what I would ask is that following on from the meeting or sometime later today, you access the Trust's website. Just when you have a few minutes, there's a really good video on there about patients living with dementia in Lincolnshire. They've had their stories told and their memories captured in a really powerful way. And the video is called Dementia, Telling Stories Through Our Hands. So I'd really urge you to have a look at that video. You will really value that experience. And thank you to the staff of Langworth Ward and the patients of Langworth Ward for preparing that video for us. Today we have apologies from Kevin Lockyer, the chair of the organisation, from Di Bailey, non-exec, and from Chris Wright, non-executive director. So we're going to go straight now into the meeting and look at declarations of interest. So declarations of interest is available in 1.2. If there are any other declarations that any members have throughout the meeting, just let me know, flag it up for me. So on to 1.4, which is the schedule of actions. Are there any actions from that anybody wants to highlight? I think they've all been basically either achieved or they are currently in progress. I'm not seeing anybody highlighting any actions. So now I'd like to move on to the minutes of the meeting, which was held on the 30th of March. Are there any amendments from that meeting or anything anybody wants to raise? Okay, thank you. I'm not seeing anything in the chat bar, so I'm going to accept those minutes as an accurate record of that meeting. Moving on, 1.5, the chair's remarks. Unfortunately, the chair can't join us today, so I'm going to move straight on to 2.1, which is the Chief Executive's report, and invite Sarah to introduce herself.
Thank you very much, Sharon. Good morning, everybody. I'm Sarah Connery. I'm Chief Executive here at the Trust, and I'm presenting this month's Chief Executive's report, giving a high-level overview of key national and local issues that might impact on Trust strategy, plans and priority setting. So to start off with, my usual cover of COVID-19 updates, and which the report highlights various changes to our infection prevention and control measures. This is part of our Living with COVID approach, and as the Trust has always done from the start of the pandemic, is to move in line with the national guidelines on infection prevention and control. I won't go into the detail, but just to say we do, despite the changes to the mask wearing guidance, do still want to make sure that we're encouraging all of our staff and patients and carers to adhere to really strong infection prevention and control measures. We are seeing a number of outbreaks across the Trust and indeed some sickness within the board itself as a result of COVID, so it definitely hasn't gone away. But it's something that we are continuing to monitor on a risk-based approach. I've also included in the report some updates from some national events there. There was an NHS leadership event with NHS England and also the Mental Health NHS Confederation annual conference and exhibition. And I always feel it's a real privilege to be able to attend these events. And I've included there the learning. And I think something that I'm really delighted about is the NHS England's sort of pledge to take a more continuous quality improvement approach going forward to performance management within the NHS. Also, there's a piece of engagement going on. A really important milestone for the NHS is our 75th birthday coming up in the summer. And there's a piece of engagement going on with the public as well as staff in the NHS in terms of what does this mean, what are we proud of, and what we'd like to see deliver going forward. So really welcome everybody to get involved in that piece of engagement work. I've included some detail around the pay deal, but also just want to point out we have had industrial action again with junior doctors, and I want to say a massive thank you to everybody who pulled out all the stops to make sure that we could keep services going with as little impact on patients as possible. We have got some ballots that are still open now for future industrial action, so nurses and consultants are being balloted, and that ends at the end of June. So we wait with anticipation in terms of what that will show. And we also have additional junior doctor industrial action planned for the 14th of June to the 17th of June. So I think we've got lots of learning from previous industrial action that we'll take into future plans as well. But as I say, all services and professions really came together to minimise the impact. So thank you very much for that. Quite a large piece of today's report is around our East Midlands Mental Health Learning Disability and Alliance. So as you've seen in previous reports, we have a common board paper that goes to all the partners boards in public to show some of the good work that we're doing together, not just about the contracted provider collaboratives such as adult eating disorder, children and young people's inpatient services, forensic services, for example, but lots of work that we're doing around workforce development, patient safety, restrictive intervention. So really learning and supporting each other around those key pieces of work. And as the report will show, we've attracted quite considerable sums of money to support us with that as a result of working together on a wider East Midlands footprint. I've updated there around the financial and operational plan process, and I know Mark will be coming on to that in a bit more detail in terms of the financial reporting. And I've also included updates around our temporary closures and consultations that are ongoing around there. We attended the Health Scrutiny Committee, so myself, Chris Higgins and Andy Ricks from the ICB to talk about our temporary ward closure, Manthorpe ward, and how this extending that pilot really gives us opportunity to extend and expand the pilot, including more around physiotherapy, dietitians, etc. So really excited about that. Just want to finish by saying some of the conferences that we've held at LPFT in terms of Experience of Care Conference, the Nursing in Care Conference, and also the Medical Development Day. Excuse me. So again, really honoured to have been asked to chair some of those events and input around our trust strategy going forward as well. So we've taken some recordings so that staff can watch it back if they weren't able to attend on the day. We're obviously really excited about our new wards opening at the Peter Hodgkinson Centre. So June's going to be quite a busy month for various visits and celebration events, which again, we're really excited about. So I'll just stop there, Sharon. I'm running out of throat, so I'm just going to take a drink, and I'm happy to take any comments or questions. Thank you.
Okay, thank you, Sarah. There's a lot of information in that report, so I'm just going to give people a few moments to gather their thoughts and you to drink your water there. You have got a question then from Tim Harry, so I'll just invite Tim to introduce himself.
Thank you, Chair. Yeah, Tim Harry, non-exec director. Sarah, thanks. And just to echo the Chair's comment, I mean, a huge breadth of activities in there. I've got one question at the Lincolnshire level around the Mental Health, Dementia, Learning Disability and Autism Alliance. And it sounded a tremendous event and a great start. And I guess my question is how that can be sort of maintained as it's an alliance and the intent around maybe holding each other to account. I wondered if you could sort of comment on that.
Yeah, thank you. It was a really great event. We couldn't make it too big bang because we were in the Purda season at the time. So what we talked about, the way we structured the day, was by looking at 3 horizons, in terms of where we are at the minute, horizon 1, where we want to be in 10 years time, horizon 3, and then how we're going to get from A to B, which was horizon 2. So we're in the process now of theming. There was so much information that came through, and we had primary care and the police, our own governors were there, you know, real broad YMCA, we had local businesses, we had educational institutions, so real broad range of views that we're now theming up. And what we're going to do is create communities of practice along those themes with really clear objectives, because sort of as I've reported previously, we've cracked on with 5 key priority objectives in the Alliance around suicide prevention, increasing community access, reducing reliance on inpatient, ensuring that people, you know, we have a mental health informed society and we're promoting mental health, and that we have a sustainable workforce. And, you know, hopefully you can see that through our IPR. The magic is what we're doing on all of those things as a system. So it might be that we come out with the same priority objectives, but we need to go through that process of theming everything up. And then once we've got those objectives, being really clear on who is holding the ring on those, and then we can get the right assurance reporting in place. One thing that we are considering is where are we actually reporting into to ensure that we have that good oversight, because this is more than just the NHS. You know, and how we're reporting into the Health and Wellbeing Board, you know, where we've got elected members, for example. So we're just in a process of trying to map all that out at the minute, which is a lot of hard work, but very exciting at the same time. I hope that answers your question, Tim.
No, it does. Thank you, Sarah. That provided a lot more sort of colour around the scheme. Thank you.
Thank you, Tim. Sarah, I'm not currently seeing any more questions for you. I just found that report really, well, there's a lot of information in it, but I thought, you know, it was very much themed around, you know, partnerships, how we're working locally, how we're working regionally, and new and different ways of working. So the pilot on home treatment and community rehab. What I found really interesting was your executive summary. And you use the words reimagining services in that executive summary. And then you pose the question around taking those services and from ambition to reality. And I just, you know, thought that was a really good way of questioning whether what we're doing as an organisation, whether we're on the right track. So while we're reimagining services, are we taking that from ambition to reality? And I just wanted your view of the chief exec, whether you thought we'd got everything right around that. Did that make sense, Sarah?
No, it does.
Because I think it's a really good question.
Yeah, it's a tricky one, isn't it? Because I think it's in certain service lines, I think, and we've showed this with older adults, that we can transform within investment by reimagining services. For other areas, I think it very much will rely on additional investment and hopefully reshaping what our mental health investment spend and our learning disability investment spend looks like, and autism and all of those threads, and dementia, and reshaping it less on prescribing and more on early intervention and prevention. I think our new trust strategy, I think the refresh of that, you know, we really have to be clear in terms of delivering that vision, what we need from a revenue, a capital and a workforce point of view to make it a reality. But the key thing for me in all of even if we had all of those things aligned, is the empowerment of our staff, because they know better than we do what patients and families need. So it's how we as a board are going to set the culture of empowerment and learning and giving something a go, and maybe getting it wrong, but we're doing it for the right reason. So, you know, we'll support with that. So that's my reflections. I don't know whether anybody else wants to feedback their thoughts on that. It's a challenge, isn't it? It's a big one. So what are the key ingredients?
Yes, it is, and I think you're right. I think it's, you know, getting that strategy right, isn't it? moving forward. But I think we're quite capable as an organisation of achieving our ambition and making it a reality. So, you know, I think, you know, that your paper set the focus for that moving forward.
Thank you.
Thank you. Thank you. So I don't see any more questions, Sarah. I'm going to move on now to it's the board assurance framework with Jenna Davis. I'm going to invite Jenna to introduce herself.
Good morning, I'm Jenna Davis and I'm the Director of Corporate Governance. So as presented is the BAF and the Corporate Risk Register. To note, 2 risks have been added to the Corporate Risk Register since the last meeting. These relate to, one is the impact of strike action, and the second risk that's been added is in relation to our data warehouse. I have included within the report the full BAF and Corporate Risk Register report that was presented at our Quality Committee. The request and the recommendation from Quality Committee is that we approve the closing down of the IPC BAF risk related to COVID-19 for the reasons that Sarah set out in her paper. And we will amalgamate the IPC COVID risk into an overarching risk related to the Trust's approach on IPC. So that's infection prevention and control, sorry, acronyms. And through the board assurance framework, infection prevention and control work that's presented to Quality Committee, we will continue to oversee any risks associated with infection control and COVID. And I will stop there.
Sorry, thank you, Jenna. Have we got any questions around the board assurance framework? I'm not seeing anything coming up at the minute, Jenna. I just wanted to pick up on paper, I think it's 2D. So it's the operational side, if I'm right. Yeah, organisational risk register. There's a couple of risks there, 180 and 202. And those risks which are around the children's services have actually been open for quite a while. I just wondered whether around those risks we've got any kind of timescale around resolution. So it's the children and young people services for both of those risks. Jenna, it might be something that actually Chris would want to respond to.
Yeah, hi, yes, Chris Higgins, Director of Operations. Yeah, happy to respond, Sharon. So it was 202, is that right? No, sorry, 180, and what was the other one? Sorry,
I think it was 202, Chris.
Ah, right, okay. So with 180, which is about the waiting times for children and young people services, we've previously reported to board, and there's an update in the integrated performance report this month that we've got, following the pandemic, we had a significant increase in the volume of people being referred for children and young people's mental health services, and that's something we saw nationally. We're pretty much on a par with other areas in the country in terms of the increase in demand for our services. That consequently led to a waiting list for quite a considerable waiting list for a number of people, and we've been working to reduce that over the last 12 months particularly. The main interventions around that is increasing productivity in services, and we've had increased investment into services and been recruiting staff over the last year. We agreed a trajectory for improvement with our sustainability committee previously, and we're on track to deliver that. There's an update coming in June to sustainability committee against that trajectory, but we're on track. But the target date is to have nobody waiting more than 12 weeks, which is the current commission target. by March next year, there's a variable waiting time for people depending on the level of risks. Those most at risk will get seen prioritised over those that are least at risk, and there's a multiple reasons why people wait, but ultimately there's a trajectory that is due to complete by March next year, where we'll have nobody waiting more than 12 weeks to access care and treatment, and then progress on from there to reduce that down to 4 weeks, which is the ultimate ambition. In terms of the access around inpatient beds, that's an ongoing risk, and I did consider whether we need to reduce the risk score on that, but after we've had a conversation with the division, we still think it's a high risk, because what's happening is, whilst we've got a provider collaborative that we're part of across the region, and we can access beds for our general adolescent patients, there are cases that have got quite complex sets of needs that are often cases that aren't easily to find a bed for, and they're patients whose needs can be difficult to meet, and often will be patients that are in ULHT, for example, our local acute provider, who may have completed their physical healthcare treatment and can't place. So there's a complication around that that's not quickly to resolve. So things have progressed in access to beds for our general adolescent population. We need a solution for the children and young people with quite complex needs. Just to say, there's a programme of work through our transformation programme that's jointly delivered by LPFT and the local authority to really explore that and come up with some options around that. So I can't put a specific time frame on that one, but it is work in progress and something we need to resolve. Ultimately, we'll have an options appraisal at the end of that once we've done that groundwork.
Thank you, Chris. That's very helpful. We have a question from Ian, so I'd invite Ian to introduce himself.
Thanks, Chair. Ian Orrell, non-exec director. Yeah, my question really was about the sort of one of the new risks that's been introduced by Jenna in relation to industrial action, and it links to the Chief Exec's report earlier, really, around the junior doctors' previous industrial action, and I just wondered, I'm not sure who this is best placed to answer this, but I just wondered if a bit more could be said about what we learned from that previous episode of industrial action, and how some of that learning is being played into the sort of risk mitigation that I guess is very much pertinent as to why the risk has been introduced onto the risk register. Thank you.
Shannon, I'm happy to take if that's okay. You're on mute, Shannon.
Thank you, Girish. Yeah.
Thank you. Good morning, all. I'm Dr. Girish Kunigiri. I'm the medical director for LPFT. Thanks, In. So we do provide a regular update to our executive team in terms of what we have learned and what mitigations we are putting in place. So this is the third time we will be having the industrial strike. We had the preparation meeting yesterday as well. So in terms of the key learning is in terms of providing our service users and carers enough time if we are cancelling the clinics, particularly in the community, and ensuring that they are given the appointments as early as possible, after the cancellation. So that was our first learning. The second learning is in terms of prioritization of the services. So, during this period, we made it that the on-call will be the first priority, followed by the inpatient unit, followed by the community services. So we are doing in those lines. And the third thing is in terms of movement of the staff. So, based on the priorities, so we had to move and redeploy some of the staff from different wards to the areas where they were not, and also from the community. So we did a mapping exercise to ensure that there is adequate medical workforce. And we also used the non-medical workforce to support the medical workforce, including the pharmacy, during this period, which was definitely helpful. One thing we still need to learn is in terms of good data collection, in terms of the number of patients, who were affected because of this, and by when they were given the appointments, and also, how many doctors, are unable to come because of the strike actions. Particularly in the last session, some doctors chose to come in the morning, but not in the afternoon. And it became very difficult, to collect such kind of data. So this time we are using QR codes, which will be sent to the doctors, so that whichever doctor is coming to the shift, they need to just scan those QR codes so that it is electronically collected, so that they are paid appropriately, and we report it appropriately. So these are some of the learnings we had. Thank you.
Thank you very much.
Thank you, Girish. And thanks for the question then, Ian. I'm not seeing any more questions, Jenna. So the ask from Jenna is that we approve the board assurance framework and the closure of that risk, which is risk 205. So can I ask for confirmation in the chat bar that everybody's happy to do that? That's great, Jenna. You're getting that confirmation. Thank you. So I'm going to move on now to the highlights and exception report from the Quality Committee, which is 3.1 on the agenda. And Di isn't able to be with us today, so we are going to have that report presented by Sharon, and I'll ask Sharon to introduce herself.
Thank you, Chair. Morning, everybody. My name's Sharon Harvey and I'm the Director of Nursing and Quality here at Lincolnshire Partnership Foundation Trust. So the Quality Committee Highlight Report is for information for the Board of Directors, and the purpose of the report is to provide highlights and exceptions from the committee for quality that was held on the 4th of May. This was our formal meeting, so colleagues will remember that we alternate between a formal meeting and a meeting where divisional representatives join us so that we can triangulate the different issues around quality across the organisation for clearer assurance. I'll take the paper as read, but there's two items that I want to just draw attention to. There were two items for recommendation for the board to approve, in addition to the item that Jenna has already raised. The first one of those is the Patient Safety Partner Declaration. That's a separate item on the agenda. But the second one is the Trust Safeguarding Declaration, which there's been an omission, and I'm really sorry about that it should have been included, and my fault it hasn't been. I wondered if I could recommend, Sharon, that we circulate that remotely, and as soon as board colleagues have had opportunity to review it, that we, if they're in agreement to approve it, we put it on the Trust website so that it's transparent to our public, if that would be acceptable.
Yes, I think that's a pragmatic way forward, Sharon.
Yeah. Otherwise, I'll take the paper as read, but really happy to take any comments or questions from people.
I'm not seeing any questions yet. Oh, hang on, Tim has a question for you, Sharon.
Hi, Tim Harry, Non-Exec Director. I was just curious about there was a section about research and development and the long-term aspiration about moving to get university hospital status. I wondered if you could just elaborate in terms of, because this is a point of ignorance from me, more than anything else, my education, about what elaborate on what the benefits will be of actually getting a university hospital status and what it will mean for the trust.
Thank you. I wonder if it would be okay to ask my colleague Girish to respond to that. Would that be acceptable both to Girish and to yourself, Tim and Sharon?
Yeah.
Dr. Girish Kunigiri, Medical Director. Tim, sorry, can you just expand that question, please?
Well, I read in the report about the research strategy has a long-term aspiration behind it to move to obtain university hospital status. And I just wondered what that actually meant in sort of practical benefits to the trust of actually achieving that status? I mean, it just sounds a wonderful thing to do, but I just wondered what practically it meant.
Yeah, so there are two elements to that, Tim. One is with regard to what does that mean to the organization as a whole and to our patients, and the second bit is you know, what is that as an organization we'll have to do to achieve that. So with regard to the first one, obviously if we achieve the university status, we will be having a large number of academic clinicians working within the organization in liaison with the University of Lincolnshire, which will obviously increase our research capability and capacity, particularly in terms of doing some original research, because at the moment our research team is really good, but we are focusing mainly on NIRH studies, which are you know, which are basically multicentric studies. So we are a part of it rather than being our own original studies. So that will be the key benefit. The second is you know, having that university status will also help us to amplify our ambition of rural and coastal mental health research, because that is an area which is lacking, and that is which we need as an organization. And the third thing is having that status will also help in terms of improving our service evaluation and expansion of the service, because at the moment we don't have the expertise and skills in terms of evaluating some of the changes we are bringing and how we spread this to other organizations. Although we have done some excellent work in terms of reducing our out of area, closing some of the wards and so on, but it needs to be done in a structured way. And lastly, this status will also help in terms of developing multi-professional research skills. I mean, at the moment it is more medically led, but there is an ambition of including other stakeholders as well into this. The next bit is in terms of achieving this, unfortunately, the bar has gone significantly higher. The trust needs to have at least 20 consultants, you know, who needs to have half-time clinical and half-time academic posts with the university, which at this moment we will not be able to achieve. And the second thing is the organization also needs to show, before we get that status, that our annual turnover is up to 200. I mean, we have at least 200K turnover every year in terms of getting external funding, which means that we will have to invest significantly before we can actually achieve the state where we can have such a annual turnover and growth before we can apply. So we need to have that for at least 3 successive years before we apply for the university status. Hope that helps.
No, thanks, Girish. And I guess a potential knock-on benefit with that prestige will be in terms of assisting in terms of recruitment.
Absolutely.
Yeah. Thank you.
Thank you.
Thank you, Girish. So Sharon, in terms of this paper, we need to note that the safeguarding declaration will be circulated. Is that for approval of board members?
Yes, sorry,
Yeah.
yes, it's for approval and then for uploading onto the website. It's our annual declaration.
Okay, so if we note that down as an action, and then in terms of the Patient Safety Partnership Declaration, is that for approval today also?
It is, and it's a separate item on the agenda this morning. I don't know if you're...
Yes, yeah. So if we could indicate in the chat bar whether we approve that declaration. Can't see any reason why we wouldn't, Sharon, but due process. Yes.
To provide some additional assurance as colleagues are doing that, we strengthened the declaration as a recommendation from Quality Committee to show our commitment to employing people with a lived experience as part of our patient safety agenda. So just to provide that additional assurance to the board.
Yeah, thank you. Right, thank you. So we're going to move on then, and we stay with you, Sharon, then for the inpatient staffing establishment paper 3.2.
Thank you. So this paper, there's a requirement for me as the Director of Nursing to present to the Board of Directors twice a year an establishment review of our inpatient services, and that's in line with the National Quality Board requirements and the Developing Workforce Safeguards guidance. So this paper is to provide assurance that the required establishment review has been undertaken. You'll see in the paper that there's no recommended change at this point to the establishment. That's because there was significant recommendation to an increase in establishment in the last review. So 17 whole-time equivalents we increased by, but also we converted registered posts equivalent to 32.9 whole-time equivalents in the November Safer Staffing Establishment Review. And because that was such a high increase, it wasn't actually agreed by the ICB, our Integrated Care Board, until April. And so we haven't realised that change yet. So it's now included in the ward establishments as of this month. But because those big changes hadn't already happened, we weren't then recommending any substantial changes or any changes to the establishment review in this review. However, we're required to do the review twice a year, so we still had to go through the review process. The future establishment reviews, based on feedback from the executive team and colleagues, future establishment reviews will include a quorum of who's part of the establishment review to ensure that we have multi-professional scrutiny. So there is already an element of that, but we, as an organisation, when we've discussed it before, we want to make sure, for example, we don't go ahead if we haven't got medical representation, if we haven't got psychology and AHPs as part of the conversation, and also making sure that workforce and our human resources team are part of that discussion as well, so it's as meaningful as it can be. So I just wanted to add that additional information. Otherwise, I'll take detail of the paper as read, but I'm really happy to take any comments or questions and answer what I can.
Thank you, Sharon. I'll give people a moment to come up with their questions. I found this a really helpful paper and quite readable and straightforward. I think Tim has a question for you, and then I've got one as well at some point. Tim.
Yes. Sorry, it's me again. Sharon, thanks for the report, and yeah, it's such an important one, isn't it, and understanding it. Again, could you a point of clarification from my ignorance, but the you referred to the increase in WTEs of 17 and the change from non-registered to registered staff. What's the change is a change for some staff who are currently incumbent staff, presumably, and therefore I just wondered what the implications were for those sort of individuals. What have they got to go through a process to become registered, etc.? Is that a longer term development piece, or how does that go?
Yeah, so it's a mixture really. So for some individuals, we're supporting them to go through their training to become registered professionals. We'll also be looking to recruit people in on a kind of recruit to train pathway. So it's a bit of a mixture really. And some of it will be a longer term plan. So where we've got a vacant post and we can recruit a registered professional into it, that would obviously be quicker, but in other ways it's a longer term plan, so it's a bit of a mix of all of those things, if that makes sense, Tim.
No, it does, Sharon. That is what I thought, but I just wanted to clarify that. Thank you.
Thank you, Tim. You have a question from Ian.
Thank you, Chair. Yeah, mine's I guess a slightly bizarre question in a sense, Sharon, but I noticed on your table where you talk about agency spend, and I know we've got an agenda in terms of trying to manage that as best we can, but in terms of the comparison with our comparators that you you've got in there, we're doing really well. And the reason it's a bizarre question is I just wonder, what is it we're doing really well? And can we do more of it?
Very good question. I don't know whether there's any other colleagues that might want to support me in answering that, Ian, and if not, I will go away and try and get you some more information. I'm sorry, I can't answer that on the spot. Is that all right?
That's absolutely fine, thank you.
Thank you, Ian. So if we put that down as an action for Sharon to come back to you,
Thanks.
is that all right?
That's fine,
And
thank you.
Amy has a question.
Hi, I'm Amy Beaton, Director of People here at the Trust. Sharon, just in Appendix 1, it does say that AHP roles sit outside the ward roster and therefore only nursing establishment can be identified for each ward. So in the column around registered a professional establishment, is that likely to be higher than this because it's just counting nurses at the moment?
I think generally, yes, but I do think it's nuanced depending on different situations. So again, if I clarify that in more detail and maybe we work through it, Amy, because there might be different things as an iterative process that we want to look at in future establishment reviews. I think we base our reviews on the MHOST tool, which is quite prescriptive in some ways, but we need to make sure we localise it for us. And the other thing as part of that conversation, I wondered if board colleagues, it's quite common to have fairly regular board development sessions on the establishment reviews, and it's a recommendation as part of the establishment reviews. So perhaps to enable other board colleagues, given it's such a priority area for us to have the conversation, we may want to consider at a future point, given we've got relatively new executives and non-executives, myself included, we might want to have a future session as a board on how we would want them to run. But I don't know if that's something people would be interested in. But I can get more specific detail on exactly that, Amy, because for some of our posts, they will be included because we would bring in either an AHP or a nurse. Another, if they've got a really clearly defined role, it might be different. So I think it's nuanced. It's a long, very long way of answering that question.
No, that's fine, Sharon, thanks. And and happy to support in that, because obviously the increase is registered professionals, it's not nursing, and so I think it's really important we capture that, and I'm happy to support.
And we have allowed, sorry, just to come back on that, we have allowed for real flexibility on the increasing of those registered posts about what they look like. So we haven't specified exactly what type of registered post that is, to allow for that creativity of thinking and development roles and succession planning through the clinical pathways as well.
Thank you, Sharon. Just in terms of that question around whether we bring it into the development session, I'm going to ask Jenna to look at that as an action, if that's all right. Thank you.
Thank you.
Okay, can I just ask, before we close this agenda item, the care hour, I'll have to start that again, care hours per patient day, which is on page 3. We're lower than our peers, so that's the care hours per patient day. I think it's looking at the clinical versus administrative type balance, isn't it? And I just wondered whether we fully understood why we were lower than our peers in terms of care hours per patient day, because it's really important, isn't it, that we have that, clinical focus around the patient.
Definitely, and I think we're trying to understand that a bit more. But also there might be a different way that we want to analyse that collectively, because if we combine our care hours per day across our organisation, we've obviously got lots of different types of clinical wards and different types of presentation. It also wouldn't ordinarily include the one-to-ones, because this is about your core establishment. So in some of our wards, of course, there'll be different times and different points around when people have one-to-ones. It wouldn't be automatically included in here, if that makes sense. And I think we could also pick that up as part of board development and get a bit more detail around that, if that would be comfortable with colleagues.
Thank you, Sharon. So Jenna has just confirmed that safer staffing, including establishment and care hours per patient day, has been added to the board development session, and Sarah would like to comment.
Yeah, just to add to what Sharon said, something that we've been talking about, and you know, Sharon's been trying to get out to as many services as possible, and something that we all hear a lot, I think, is the amount of time that people spend in front of computers doing paperwork rather than caring as such. So I think care hours per patient day is quite blunt in that it sort of measures registered staff. It doesn't give an accurate picture of how much of time of that registered staff is spent sort of in a sort of therapeutic relationship with patients, as opposed to so we're trying to, it's not an easy, we're trying to work out what the best approach is to deal with that, and I think it might be something significant that we may need to invest in to really get to the bottom of that, learn best practice, see what other trusts are doing to try and free up, to use an old vernacular from a few years ago, you know, releasing time to care. So it's layering on the care hours per patient day. Well, what does that actually mean in terms of patient experience? If that makes sense. Thank you.
Yeah, thank you, Sarah. So we look forward to that development session. Thank you. So I'm going to move on now to paper 3.3, which is learning from deaths, and we're with Girish for this paper.
Good morning again. I'm Girish Kunigirip, the medical director in LPFT. I guess that you all had the chance to have a look at the paper. So this is to summarize with regard to unexpected deaths, which has happened in the organization for our users and also for those who have used the service, but they were discharged 6 months before the unexpected death. So in terms of learning from deaths, you know, we have 3 parts. One is those deaths who meet the threshold of what is called as serious incidents. The next one is in terms of mortality care reviews. And then the third is the leader, which is basically deaths of all you know, service users who have a diagnosis of learning disability and autism, which is done at the ICB level. So in terms of the changes, what has happened since the last report, there is a national pilot of developing community medical examiners. These are not necessarily psychiatrists, but you know, each of the ICB is expected to have few community medical examiners who provide an independent scrutiny of the deaths in a timely fashion, and also they support the clinicians in terms of completion of medical certificate of causes for death, and also they provide expert advice to the doctors and support in terms of providing the feedback and learning, in addition to providing expertise to the coroner if they are invited to. I think what is obviously important is that how we as an organization learn from these incidents to ensure that we have the right process in place to avoid these things happening. So we have a bi-monthly mortality surveillance committee where we look at all the you know, necessary mortality case reviews along with the leader cases and also some of the SIs, and they all feed into what is called as organizational learning meeting, which is a multi-professional meeting. And what as an organization we are doing is we are collecting all the themes which are coming from different sources, and then we are trying to put those themes together, and then we are cascading to the divisions which are specific to the divisions, and also those themes which are cross-organizational, so that there is cross-organization learning which happens. The framework what we have developed in the organization is in line with the national framework, which is called as PSIRF, which is Patient Safety Incident Response Framework, and the organization learning meeting helps to triangulate the different learning which happens alongside the complaints and patient safety incidents. So we currently have the robust plan. As you can see in the report, that some of the unexpected deaths which have happened for people with learning disability and autism, some of the issues which have been raised, which we are looking into, is in terms of how we help in terms of managing the physical health issues, and how we as different providers within the organization share the data, and also in terms of having robust mechanism of data reporting. Obviously, you see that since January 2021, there was only one unexpected death with autism, and we feel that there are more in the community, but this is something which is a process which we'll have to take. But having said that, there are some quality initiative programs which has been in place, particularly looking at the learning disability annual health checks, and also in terms of moving forward, what we are planning to discuss in the next organization learning meeting is, in addition to bringing all this learning together, how clinical teams are involved in making the recommendations, and how this learning is incorporated into some of our QI programs. So that is the next step we are taking into account. So I'm happy to answer any questions. Thank you, Sharon. You're on mute, Sharon.
Thank you, Girish. Are there any questions on this report? I think Amy's typing, so while people are typing away, yes, you have a question from Amy first, Girish.
Hi, Amy Beaton, Director of People. Thank you, Girish. I just wondered on page 7, where we are seeing the key learning, whether it'd be helpful to see what we're doing around some of the quality concerns and the emerging risks. So they are listed there, but I think it'd be really helpful because it does make reference into the report that the Trust's Transforming Care Lead is overseeing the action plan to embed relevant recommendations. And I think rather than just seeing the concerns, it'd be good to see the recommendations that are being implemented as a result, if that's possible.
Yeah, thank you. I think that's a good suggestion, Amy. I will take this back, and I need to, as a team, we need to think how we bring this, because if I bring all the action plans, it will be too big, and whether we can do it in a way so that we can bring themes and what we are doing with the themes, that may be helpful. Yeah, I'll take that action. Thank you.
Thank you.
A really, really good challenge, Amy, and it'll be good, Girish, to see how you manage to get that into the report, flavour of that into the report. We now have Tim, who has a question for you.
Yeah, Tim Harry, Non-Exec Director. Girish, thanks very much for the report. My question really follows on and is similar to Amy's, but it's specifically in the appendix as reference to the Trust electronic recording system. And there's a couple of areas where it seems to be part of a problem for information flows for staff, etc. So obviously really good it's been identified, but similarly, what assurance have we got that something what is being done about it, and is it being effective? So that's my question. Thank you.
Yeah, thank you, Tim. I was the Chief Clinical Information Officer for 7 years before I came here in my previous organization, and as the number of years go far and far, the amount of information what we have on the electronic system also keeps building, and people really struggle to get that. Having said that, what as an organization we are doing over the last few months is that we have commissioned a project to get the feedback from all the users of our patient electronic system to see what is good about it and what is not so good about it, and what are the key priorities where they want us to make a change. So there are lots of engagement events which have happened, and the report will be produced quite soon, and which is the first phase of the project. And in the second phase, the plan is to identify the priority areas where we will have to focus and bring some remedy to this ongoing issues with the patient electronic records. Thank you.
Yeah, thanks, Girish. And it's really heartening to hear that, you're involving the people who probably got the solutions there in that process. Great, thank you.
Thank you.
Thank you, Tim. I think we have Mark now who has a comment.
Brilliant. Thanks, Chair. So good morning, everyone. Mark Platts, Director of Finance and Information. It was just to build upon Girish's point there, that the review of our system has included, we've interviewed over 150 people, and that's gone from administrators in the system to lead clinicians. So we've got a real breadth of data there and knowledge that we are going to use to work with the provider to change and tweak as we need to make sure that we can get the best use out of our data that we have in the system. So it's a really positive report. We'll keep updates coming through Sustainability Committee, and then board will hear the findings from it as well. So thanks for that.
Thank you, Mark. And I believe, Girish, that is all the questions on your report. So thank you for presenting that. I was particularly impressed by the work done around journey of learning and the work the team are doing around that. I thought it was really good. Thank you. So we move on now. Now we have got the Patient Safety Partnership Partner Declaration on the agenda. However, we did take that as an agenda item with the Quality Committee narrative report. So I'm just going to check with Sharon whether there is anything else that she would like to come back on that. Otherwise, we have approved that declaration.
No, that's fine. If people are comfortable, that was the purpose of that paper, Sharon. So I feel we've covered that, if that's okay.
That's great. Thank you, Sharon. Okay, so we move on now to the highlights and exceptions of Sustainability Committee. And I'm going to invite Tim to take us through that paper because the chair of the committee isn't available today.
Thank you, Sharon. Yeah, Tim, Harry, Ned, so member of the Sustainability Committee, doing this on behalf of the chair, Chris Wright. So as usual, assume that everybody's read it, but just to pull out a few sort of key highlights from the meeting. One area of focus over the last few meetings has been around contract management and really developing it and strengthening it. So we were pleased to hear around piloting being looked for in terms of some specialist contract management resource, and also utilising an NHS framework around contract management, which would ensure best practice. Another area of focus over the last few meetings, of course, has been the outturn of financial performance from 22-23 and the proposed budgets moving forward for 23-24. I think one of the biggest challenges, and this is being reported both at trust level and for the system as a whole has been challenged from the centre, from NHS England, to look for a break-even situation in the proposed budget moving forward. That is not seen as realistic. But I think there'll be ongoing sort of debate around it. But what we have seen is a reduction in the deficit that has come down with each version moving forward. You've heard from Sarah about the good progress on the eradication of dormitories. Really good news, approaching the opening stage of the scheme at Lincoln, and good progress still being made on the planning at Boston. We had to review and approve or recommend a number of areas, points of governance around the investment appraisal framework for the organisation, the service provision within the new arrangements under Operation Courage, which again Sarah mentioned in her report earlier. And finally, we reviewed the business case for the development of informatics, which is obviously a really critical area for the business to maintain digital competency, and that's in the process of going through with the board for review and hopefully approval. But I'll leave it there and obviously open to any questions.
Thank you, Tim. Just wait and see if we've got any questions for you. Nothing's come up yet. No, I think that was pretty clear, Tim. Thank you. The highlight report. So there are no questions for you. So I'm going to move on now to the integrated performance report with Mark.
Thanks, Chair. Good morning, everyone. So I'm Mark Platts, Director of Finance and Information, and I'm here today to present this month's integrated performance report. So I'm just going to go through a quick update on some of the key highlights, and then if it's okay, just to make reference to because we didn't hold a people committee during the last period, I am going to hand over to Amy, who's going to do a bit more of a deep dive into the people section so we can add that context and pick up on some of the key messages, if that's okay. So overall, from the integrated performance report, there are elements of positive movements within there. So we have seen staff sickness and staff vacancies drop again for consecutive months, really. So we're moving in the right direction. So our vacancy rates have reduced to 15.3 from March. So we're in a much better position than we were, really. So, however, vacancy rates are still higher than we want them to be, and I know we've talked about that in previous years in terms of what's driving the financial position and where we are. So there's a lot of work streams underway to help improve that, and I'm going to leave that there and let Amy kind of pick up on a few more bits. We've touched on it earlier on. So whilst we do benchmark quite well with peers against our banking agency spend, we are actually higher than planned in our agency spend for month one, and I think this is a combination of factors, really, because there is a really stretched target in terms of our agency spend as a Lincolnshire system. So as a result of that, we've had to take a fair share of a target for our agency spend on that. So we are slightly overperforming in month one on that. So I think we do need to look at our agency use, and I think that the plans to increase substantive recruitment during the year will start to mitigate that and help us bring that down, certainly around the medical and consultant arena. So I'm confident we can pull that one back, really. In terms of the couple of the trust-wide metrics that do start to be reported on page 23 of the report, we've touched on it already. There was a question around the children and young people and the access weights and where we are. So again, we're not where we want to be. However, we are seeing some positive changes as a result of investment into the teams and being recruited. So the access rate, the 12-month rolling one, metric 13 in that table, has now increased performance for the third consecutive month, which you can really start to see the benefits of investment coming through from that one. And sadly, countering that, there are teams such as the early intervention and psychosis team who are really struggling with their staffing position at the minute, and they're having some real operational challenges. Chris Higgins, the Director of Ops, has referenced that within the operational update. We can see that sadly from the weights. So metric 16, quite a significant drop in terms of our wait time performance there, down to 45.8%, which is low, the lowest it's been for a while. We were at 94.4 in previous months. So there's a real balance there of how we've got to manage the position across the services, really. But overall, from a financial position, we have met our targets. We're broadly on plan, just a slight small variance there, but yeah, we are 1 month into the year, so the importance is that we keep the focus on the future 12 months. And I think the key thing for us out on this is the importance of our people and how we work to minimise those vacancies and maximise that stability across services. But if it's okay, I will hand over to Amy to do a bit more of a deep dive around the people elements of the report.
Thank you.
So, hi, yes, Amy Beaton, Director of People. So, just to add a bit further contextualisation on the sickness that Mark's referred to, because I think I'll take away how we actually represent our data, because the percentages can be misleading. So you'll see reference to stress and anxiety and depression in April, representing quite a high percentage of our sickness in some of our areas. And it does, but actually it's increased in its percentage because other sickness reasons have decreased. So it's now representing a higher overall percent of our sickness because those other reasons have decreased. And I think just to kind of assure board, actually we reduced our number of days lost due to stress, anxiety and depression in April. So I need to think about how we represent that so that that doesn't mislead. And I think it's also worth saying that stress, anxiety and depression is the only reason we've got to categorise sickness when it's mental health sickness, where we've got 9 physical health reasons to spread across. So it is always going to be our highest reason for that categorisation. That's not to say we're not taking action. As Mark has said, it's an absolute priority and focus for us, and we're working with our staff wellbeing service. And it's also a key priority for us in the integrated care system in the people team. Health and wellbeing is a real priority on what we can do together in that space. I would also highlight that we've seen a statistically significant reduction in turnover. And in April, just to confirm, in all our clinical divisions, we saw that reduction continue. So 2 of our 4 clinical divisions are below the trust target, and the other 2 did continue to reduce, although not being there. The slight rise we've seen, although we're still below target this month, is in our corporate division, and it is something that we will be keeping our eye on and monitoring, as hybrid working has opened opportunities for corporate staff in particular to work further from home. So that is something that we are looking at. But the main drive in that turnover reduction, we can see flexible working and our focus on team effectiveness out of our Walking in Your Shoes staff engagement programme asked us to focus on those areas. We have, and we can see when we bring back to board in July our national quarterly pulse survey, we will see those areas have really improved. And then finally, as Mark referenced, we saw our vacancy reduce again in March. However, we knew this is not going to be sustained because of the investment increases our budgeted establishment. So in April, we expected our vacancies to rise, and it's managing that tension of getting more investment, but then the scrutiny attracted from the higher vacancy position. But I think it's worth focusing the board on page 17, the graph in page 17 of the report, as that really does demonstrate our recruitment plans are delivering. So our actual whole-time equivalents is higher at the end of month 1 than what we actually planned, and that graph shows that is 58 whole-time equivalents higher at the end of month 1 than what we planned, and actually that overperformance has been achieved since January to April, and that has been achieved because we've continued to reduce turnover. We have our attraction strategy and our robust plans for recruitment, and we've seen a reduction in our time to hire by 40 days per hire since we've introduced our recruitment system track in November. Thank you, Sharon.
Thank you, Amy. Just in terms of the health and well-being of staff, I know we didn't have a people committee as planned earlier in the month, but there is one at the end of the month. I wonder if we could ask the committee chair to make sure there's, a clear focus on the health and well-being of staff throughout that agenda.
Yes, and we've got a planned deep dive on the forward agenda of People Committee around health and wellbeing. And I would say our national staff survey shows staff believe as an organisation we really care about their health and wellbeing. So we're trying to understand that stress, anxiety and depression metric when we've got that as a context as well.
Yeah.
So we're digging deeper into that data a bit more.
Thank you. Tim, did you want to come in here?
Yeah, no, absolutely. And it's certainly there in our minds around health and well-being, and we are very aware that we've had a particular strong focus on recruitment and retention, but we mustn't lose sight of all the other aspects around people. So Amy and I have got, I think we've got a discussion tomorrow, haven't we? And it was certainly on my list to sort of pick up, and we will pick it up at the committee next week, I think it is.
Thank you. Thanks, Tim. So, Mark, are there any other aspects of the integrated performance report that you want to highlight?
No, thanks, Chair. That's it. Thank you.
Can I just ask, it's a very small question, but one I feel I should understand. On page 21, where it talks about liquidity days, I understand the concept of liquidity days, you'll be glad to know, as the Chief Finance Officer, but that last sentence where it says that we are measured against a 0 by NHSE, and we're currently obviously significantly higher than that. What is the meaning of that? Does it mean anything, or is it just an in-month position?
Yeah, thanks, Sharon. It's a good question. So basically, the bigger days, the longer we are liquid. So from an NHS England viewpoint, as long as there is cash in the bank to maintain the future needs, the stronger the better. And I guess that benchmark of 0 is to make sure that no NHS organisation goes out of trust. So if there are cash deficits, they will be topped up as required through those escalation processes. So it's just a benchmark. We're in a sound position as an organisation from a liquidity days viewpoint. And I think from an NHS perspective, it will just be that 0 target is to make sure that trusts don't get into the position that they can't pay their staff or creditors.
Okay, thank you for that, clarifying that for me. Thank you. So we're going to move on now to the highlights and exceptions of the audit committee, and Ian is going to take us through that.
Thank you, Chair. Before I do, would you mind if I asked a question just on the previous report? And I was reading it at the same time as the conversation was going on, so sorry if I've missed the prompt. Is that okay?
Yeah, that's fine. Go ahead, Ian.
There were just a couple of questions I got. Was first of all, in page 17 that was referred to, some of the staffing issues, and if I was understanding that draft correctly, it looked to me as though the growth was clearly taking place during the first 6 months of the year, but then we were flatlining thereafter, certainly in terms of the graph. And I just wanted to see whether my understanding was correct on that, because if that's the case, we will still have this, bulk of vacant posts. So I'm not quite sure who that's aimed at. And then the other one was one that Mark introduced in his presentation, which was about the psychosis weights and the staffing vacancies. And I just wondered if a bit more could be said about the position there and what we're doing to move those staffing vacancies on. So apologies to delay things, but
Ian, just to cover that, if we ask Amy to cover the question around staffing, and I think Chris will come in then on the operations.
Thank you very much.
Thank you, Sharon, and Mark, please come in because I know your finance have built the graph. So Ian, which lines are you looking at? So the orange line obviously represents the plan for our existing vacancies, and the green represents when we've got that ICB investment, and then the dotted red line at the top is our current vacancies.
Yeah,
so
sorry.
No, so the two lines within divisions, what divisions have done is phased the investment, and what our predicted reduction in vacancies would be against our existing vacancies across the year, and have based that when we know, for example, we know it's particularly January, we will see a spike because we have NQNs, newly qualified nurses, for example, start there. So we have certain times of the year when we do see more coming in, and that we phased that across. And so the divisions and the HR business partner have worked across the 12 months on when they see that phasing coming in.
Okay, that's helpful. I don't know whether I'm going sort of beyond what was in the paper, but I suppose what caught my eye was, yes, we're moving in the early part of the graph towards the dotted line at the top, which is where we'd all love to be, and we know that's an enormous stretch. But I suppose if we got year 2 in there as well as just this year, would that be demonstrating a further narrowing towards the dotted line at the top?
Yes, we would expect it to be, if we didn't add any further investment in, which then increases vacancies. So the vacancies go up as the budgeted establishment is added to. So as long as we stopped increasing our budgeted establishment, we would close the line.
I've just asked Mark to come in here, and then I think, Ian, we're going probably into some of the detail of the meaning of the graphs on the integrated report, and it's probably something outside of the board that we need to pick up.
Yeah, okay.
Yeah, brilliant. Thanks, Sharon. And yeah, I'll take it back to the thing, because I don't think the scale of the graphs help, because it doesn't look like it's a significant increase, but actually from month 6 to month 12, it's 100 whole times. And bearing in mind, we appointed a net 190 last year. It's the graph more than the process, I think. So I'll take that back to the team, Ian, and we'll adjust it as we need to.
Thanks, Mark. So thanks for highlighting that, Ian. It's under development as a performance report, and we just need to make sure that it's telling us the right things in the right way. So that's useful. So if I could ask you to go on then to the audit committee highlight report.
Okay, yeah. In terms of that, I guess people will have read the report. In terms of issues we were sort of involved in, I suppose I'd particularly highlight the annual reporting cycle. It's that time of year when Mark and his team are very much involved in producing the final accounts. We also looked at the annual review of governance arrangements, which is coming on to the agenda later this morning, and we received the usual reports on counter fraud and freedom to speak up. The only other thing I perhaps want to add is that the new internal audit provider took part in this particular session as well for the first time. But other than that, that's I think all I'd need to say. Thank you.
Thank you, Ian. Are there any questions on this agenda item? I'm not seeing anything. No, not seeing anything, Ian. Thank you. So we'll move on now to, I would normally say let's take a coffee break. However, we're so far ahead in the agenda because we didn't have the patient story today, that if everybody is happy, I'd like to carry on and move on to 6.2, which is the annual review of governance with Jenna.
Sorry, I was struggling to come off mute then and unmute myself. So this report gives the board assurance that we are compliant with national guidance, national standards in terms of governance, but it also outlines some of the areas of good practice that we meet as well. So Audit Committee has received assurance through this report, and it's a more detailed report that goes to Audit Committee, and this is a condensed version. For assurance, the board remains, and the trust, remains compliant with our national standards, and there's a paper as part of the annual processes due to come to board in June against our licence that says that we are compliant. The Audit Committee, as Ian alluded, has received assurance through the report, and a statement has been added to this paper, and the board is asked to confirm it's satisfied with the trust governance arrangements and that we are compliant.
Thank you, Jenna. So could I ask for you to put into the comments bar a yes that you're happy that we are compliant, or a no that you're not, and then we'll need to discuss if there are any no's. Jenna, you're getting yeses. You'll be pleased to know on that one. I think we're still with you for the review of the Trust Constitution.
Yep, so in line with the Health and Social Care Act, we are required to review our constitution on an annual basis, and then the constitution is approved by Council of Governors together with the board. So this has already been to Council of Governors and approved. The proposed amendments are clearly outlined in the paper, which relate to changes to the constitution based on the legislative changes we've seen recently. And we've also added a new stakeholder governor because of our close relations with the police. So that's really great to have a stakeholder governor from the police. Because we're undertaking a well-led governance review this year, we haven't done any major changes to the constitution, as there will be changes on the back after the well-led review has concluded.
Thank you, Jenna. So can I ask board members to indicate in the chat that they are happy to approve the amendments outlined? Okay, Jenna, you have your approval for those amendments, and I think you're going to take us through the forthcoming board programme now.
It's there for information, and I'll just take any questions if anyone's got any.
Are there any questions for Jenna on that forward board agenda? I'm not seeing anything come up. I'll just give them a few seconds to gather thoughts, Jenna. No, I think everybody's happy with that. So we'll move on now to the investment appraisal framework, item 8.1 on the agenda, and with Mark for that.
Brilliant. Thanks, Chair. So good morning again, Mark Platts, Director of Finance and Information. So this has been presented to board for approval today. So the revised investment appraisal framework has been reviewed by the Sustainability Committee, and we did talk through it in a lot of detail, to be fair. So I'm not going to go through the level of detail within the changes, but ultimately this update reflects the changes that we feel are best required to keep us both up to date with the market in terms of price increases and how do we cope with that, and actually to increase that engagement and scrutiny from board members' perspective, because we have had some discussions around previous business cases, and this proposed new investment appraisal framework meets that and kind of draws the board more into discussions when we start to vary from our standard processes, really. So it's important to note we do obviously operate within a different regime now as an integrated care system, and there is a layer of complexity around our board approval to then where we take business cases and approval tenders and things through the system for funding, if we are looking at funding from our integrated care board or other partners within the system. So there is a layer of complexity that kind of needs to be brought in on top of this. That's still being finalised and we're still working through that. So whilst this is the update that reflects the needs as we are today, Chris and I do anticipate working with the business development team. We may need to refine this again moving forward, because it's important we keep it up to date and reflective, because we've got to make sure that our decisions are both informed, strategic, and the right ones for our patients. So here today for presenting for approval, and happy to take any questions, as is Chris from the business development side of things.
Thank you, Mark. Have we any questions for Mark on this agenda item? I'm not seeing anything come up for you, Mark. So can we indicate in the chat bar whether we are happy to approve?
I think Tim has just
Oh, Tim, you creeped in there.
Sorry, Chair. It's just a quick comment, and I have made it elsewhere, so apologies in that respect. Fully support the proposal, makes absolute sense. It's just a comment, you know, that quite rightly there's a focus on financial levels for dedicated approvals, etc. But there can be a judgment call involved where, simply because of an element of maybe reputational risk, which is disproportionate to the investment size, or an aggregation of various investments, and that's my only comment, but I'm absolutely fine with it as it is. Thank you.
Do you want to come back on that one, Sharon?
Yes, please.
Yeah, okay. So yeah, as part of the business case review team that look at the business cases, and they go through the detailed business case with a fine-tooth comb. So that there is a seals of approval within that, and that picks up all of the corporate and trust-wide departments, and that's an opportunity for any potential risks around reputation, no matter how small the business case, because, you know, I've had personal experience. Some of the smaller business cases can have the biggest reputational impact on the organisation and pull that through. So they get discussed at that point before then coming through our ET+6. And the idea of the ET+6 is that's obviously our executive team and 6 of the senior leaders, often deputies from the organisation. So we will be looking at those business cases through the eyes of the lens of the organisation, and reputation is one that consistently comes up in that review. So it is picked up as part of the process, and we do make sure that every business case is scrutinised from that perspective, because it's a really important one that we do have that reputation that we are doing the right thing for our patients as well.
Thanks, Mark.
Thank you, Mark. So just to confirm, can we ask for yeses in the chat bar if we're happy to approve? You're getting your yeses, Mark.
Thank you very much.
No dissents. Okay, so that brings us today to the end of the agenda for the board. The next board meeting will take place on the 27th of July at 9 AM by Microsoft Teams. I don't have any other business presented to me today, so I'd just like to thank the executives for the clarity of the reports that they've presented today, which has enabled us to get through this board relatively quickly. Thank you.